It's not really new. We know it's been around about 30 years, but there seems to be a groundswell behind it now. Why do you think that is? And give us an overview of the medical home paradigm.
Sure. So there's a big emphasis today on costs of care, and healthcare reform is probably about to pass. Two of the key items that are included in healthcare reform are bundling and accountable care organizations. And both of those will place a big emphasis on controlling the costs of care for patients with chronic conditions. I think that medical homes have resurged in part because they are an obvious way to improve the management of patients with chronic conditions.
The model for the medical home, if you say it to someone, what exactly, are you talking about actual structure, or is it a team? Could you walk us through what that model is?
Sure. The idea of the medical home is that everyone should have a primary care provider, but that additional things are needed to really make it a medical home. So there should be support for psychiatric issues, for issues around medications, for issues of related to housing. If someone needs help with substance abuse issues, that sort of thing should be available. And today, most primary care offices basically do not include access to those things.
So it's like a team concept, and if it were, like, say the primary physician is the head coach?
Absolutely. So it's very much a team. The idea is that the primary care physician is part of the team, but there are a number of components, and to get the care that is really needed, you need everybody on the team to do their part.
What are the components? Give me that team so we get a good understanding of who's involved, in your opinion, as the key members of that team.
Well, exactly how the team will be set up is still being defined, and the very best composition is not really known so far. But it's pretty clear that it should include, for example, some help with social services, because social issues are so important in terms of getting good care. It's also clear that many patients need more psychiatric help than they're getting today. Another key issue is around management of chronic conditions, and pharmacists can play a very key role, especially around medications that patients need for their chronic conditions. For issues like congestive heart failure or depression, it's very important that patients be on the right medications, that they take them regularly. If they're not, they predictably will get into trouble. And in our system today, that sort of thing just happens and no one notices all too often.
What would be the barriers to having this really take hold and become the model that's used on a wide scale?
The single biggest barrier today has been our payment scheme, which pays providers for visits. So providers get money if the patients come in and are seen. But if you, for example, invest a lot of effort and keep the patient out of the hospital, no one does better as a result of that. So it's very important for this to take hold that at least some payment reform be implemented.
That sounds as though you're asking people almost to take money out of their pockets, some of the specialists, no?
Well, certainly the money is going to have to come from somewhere. And I think it is reasonably likely that specialists will get paid less down the road than they do today. I think specialists make more than really makes sense in the United States.
So what would be the alternative if you're talking to them? Well, if we don't do this, then
if we don't do this, the costs of care will continue to escalate. The outcomes of care will continue to be poor. In the United States, the costs of health care are the highest of any country in the world, and our outcomes are mediocre or worse.
The Geisinger Clinic, you have Kaiser Permanente, they are recognized as using this model well. What can you learn from the way they implement it?
I think a lot can be learned from the way that some of the managed care organizations like Geisinger and Kaiser, and also Group Health, have implemented medical homes. all of those entities are responsible for the costs of care for their members. And they've all recognized that it's in their interests to put these medical homes in place. Group health experiences are perhaps the best described, and they've done a reasonably nice job of putting forward what components of medical homes they've included in their practice, and they're also doing a very nice job of evaluating the impact. And there's other work that will be coming out soon from Geisinger and also from Kaiser.
You mentioned earlier healthcare reform, and that's a dominant topic, whatever you're talking about in this country right now. Do you foresee that the move towards healthcare reform, whatever it's going to be, will be a motivational tool to help move along, serve as a catalyst to get more people on board with medical home?
I think that healthcare reform will definitely be a catalyst in the movement towards medical homes. There's actually a lot of support in the current bill, which of course might or might not be in what finally passes. But there's a couple of $2 billion focused on this. I think that the key things, though, in terms of healthcare reform really are the extent to which accountable care organizations get set up and the extent to which bundling is pushed as a concept. The idea of bundling is that an organization would get paid a set amount for patients with a condition like congestive heart failure, and then they would need to figure out how to manage those patients in a way that was more efficient. Doing that well will require being in touch with them when they're at home and keeping them out of the hospital. So
you think in the end, medical home will finally find a home?
I do believe that's going to happen. I think this is really the time for the medical home.
Thank you, Dr. Bates.
You're welcome. My pleasure.